Welcome to the Physician Associate Podcast.
Hello and welcome to this episode of the Physician Associate Podcast. My name is James. I'm really pleased today to be joined by Ben Gowland, who is Director of Ockham Healthcare and host of the General Practice Podcast. Welcome to the PA Podcast, Ben.
Thanks, James. Pleasure to be here.
Thank you so much for coming on to talk to us today. I wanted to do an episode that might be helpful for a lot of physician associates out there who are perhaps new into GP land and primary care. Coming into primary care, there can often be quite a lot of terms that are a bit unfamiliar, and the business structure can seem a bit foreign to somebody from the outside. So I wondered if you could explain a little bit about how general practices are set up and how the business works and some of the key terms like PCNs that are bounded about.
Yeah, well, it's difficult, isn't it? Because lots of clinicians obviously train in the NHS. The NHS is this kind of big nationalised organisation, has been since 1948. But of course, GP practices have always been outside of the core NHS. They are independent businesses. So GP practice is an independent business, and the NHS has a contract, a national contract, and it contracts individually with each of those GP practices. So it's a really important distinction, because it means that the practice really is accountable to the contract that it has and doesn't have any other real accountability within the NHS system. Obviously, it gets regulated by the Care Quality Commission, but that's against how it performs on its contract and its relationship with the commissioner. So at this point, the Clinical Commissioning Group or the CCG is as its local contract manager. So it's important to understand then, that we have these set of roughly 7,000 independent businesses that form GP practices. Now, the big change that's happened in the last few years, so there was part of the new GP contract that was introduced in 2019. It's a 5-year contract, and as part of that contract, there was an additional piece that practices could sign up to around primary care networks. So much of the investment at present into general practice is going in through primary care networks. So what GP practices opted to do, and the vast majority have opted to do this, is the GP practice chooses to become part of a primary care network or a PCN. And that's where you can have 5 or 6 practices typically working together, and they have to deliver a set of services collectively as a primary care network. But the really important thing, I think, then for physician associates to understand is that a key part of the funding that primary care networks get is this thing called the Additional Role Reimbursement Scheme. And that is a pot of money that started in 2019 and grows every year for 5 years. Out of that money, primary care networks, so these groups of GP practices, can employ a range of roles. So pharmacists, paramedics, podiatrists, OTs, dietitians, all sorts of different roles. And one of those roles is physician associates. And so the reason that we're getting this big influx of physician associates into general practice at present is because primary care networks, so groups of practices working together, have funding that allows them to then employ physician associates within their primary care network. That then creates a set of challenges for physician associates, because the problem with the primary care network is that, let's say it's 5 or 6 practices and you as a physician associate are employed by this network of 5 or 6 practices. Who actually owns the physician associate? It's a really interesting issue. So networks are set up differently. So sometimes they'll have a lead practice arrangement, or they'll have an arrangement that shares things across the practice. But whatever the sort of technical background, the expectation is often that the physician associate is expected to work across all 5 or all 6 of the practices. And that can be really difficult for a newly qualified physician associate who needs a lot of support and needs that relationship with the clinicians around them to be effective and to learn in the role that they're now taking on. And so what we're finding is that those physician associates going into primary care networks where that ownership issue, so it's kind of spread out and can end up feeling like no one's owning the physician associate, then it's proving quite difficult already for the physician associate, even in this first year of physician associates being part of primary care networks. Whereas those primary care networks where there's been a lead practice, and they say, look, we'll be the home, if you like, for the physician associate, we'll look after them, we'll make sure the training happens, we'll invest the time in them for the next 2 or 3 years, and then maybe we can start to share the service across the other practices. They're the ones where it's working better.
Yeah, you absolutely hit the nail on the head there. My concern is for these PAs that are new out of university and having their first job, being spread across 4 or 5 different practices in their week can be a really difficult thing for them, because who's accountable for their supervision, for their development, for checking that they're working as they should be, and how are they following up with their patients in terms of continuity and finding blood test results if they're across different practices all the time.
If I was a physician associate looking for a role, because there are lots of roles out there at present, the thing that I'd be focusing most on is not so much salary. And I know it's tempting to go for salary, but would be to find out from prospective employers, how will you be looking after me? How will you be dealing with this issue of the primary care network being multiple practices? So will I be hosted and looked after in one practice primarily, or is the expectation on a Monday I'm in practice A, and a Tuesday I'm practice B, and a Wednesday I'm practice C? And how is that going to work? Is that going to work in reality? And I think what we'll see is quite a lot of turnover of some of these early roles, because I think they're going into practices. The practice don't know what to do with them. They're ending up doing kind of admin level work, and they're just not going to be able to stick that out, are they? And so what will happen is the physician associates will migrate to the places where they're properly looked after. The model clearly is going to work best where there is a host practice for a physician associate. And the other is if you have a senior physician associate, so a more experienced physician associate who's able to look after and kind of advocate for the newly qualified physician associates coming into post, because the money in primary care networks is such that they can afford more than one physician associate. And so where it's working well, you could expect them over the next 5 years to end up with a team of physician associates. But then having that senior physician associate who can then advocate and look after and make sure it works is going to be something that I think is a model that could work much better than this individual model that we're seeing at present. Unfortunately, I think the challenge is actually greater for the physician associate, because I think the amount of initial supervision and support that's needed for the physician associate, particularly newly qualified physician associates, is higher than for some of the other roles. So if you're taking a relatively experienced pharmacist, they can come in and there are sets of things that they can do straight away that doesn't need, that kind of makes sense to the practice. So they understand what's the work that they're giving them. And it also doesn't require as much supervision. Equally with paramedics, so lots of primary care networks are thinking about how do we have like a home visiting service across our practices, and we can use paramedics to do that. So I actually think the challenge for physician associates is probably the greatest of all the roles in terms of practices getting used to how do we make the most of our physician associate. And from the physician associate perspective, how are we getting the support and supervision and training that we need to be effective in the role? I also think the potential is very high. So the amount of GP work that a physician associate is potentially able to take is actually higher than many of those other roles. But it takes time and investment, so it won't happen straight away. It will need the physician associate to work with that practice to get the skills and experience of different conditions and how they work. And it will help when physician associates are recognized and are able to prescribe. I think that's going to make a big difference for physician associates as well. So I think the upside is very high. I just think the starting point makes that introduction quite difficult.
Could I ask you to explain exactly what a partnership is and how that works in terms of the GP business?
Remember what we said. So GP practice holds a contract with the NHS to deliver services in that contract. So effectively, each GP partnership is an independent business in its own right. So what it means is that the GP partners, so GPs working in a GP practice can either be partners, so co-owners of the business, or they can be salary GPs, so employed by the partnership itself. So a GP partnership is the business that holds the contract with the NHS, and the GP partners are the owners. When you go and work for a practice, you're working for that business.
And being in partnership, so you obviously have your other partners with you that own the business together. You also take on some of the risk together as partners, don't you, in terms of sometimes the property risk?
Yeah, so that's right. So when you're owners of the business, so you have a share of the profits, and you also are jointly liable for any losses that the practice incurs. And general practice for many years has had challenges, not just with workload and workforce, but also with finances. There was a whole period of disinvestment in general practice, kind of from 2004 onwards, probably right up until the GP4 review was introduced in 2016. So it's not like when you're a partner of a practice that you have a guaranteed income. All you have is a share of any profits that are made. And if no profits are made, then you're not earning any income, just like any business owner. And so there are examples around the country of places where the salary GPs are earning more than the partners because the business as a whole hasn't been profitable enough to pay the partners a greater salary, i.e. share of the earnings.
And there are a few physician associates who are partners in their GP practices dotted across the country now, but that might change in the future because NHS England have just opened up the partnership payment scheme to physician associates and other non-GP professionals as well now, haven't they?
NHS England is trying to support the partnership model. And so they introduced this thing called the New to Partnership scheme. So basically, eligible participants can get basically a golden handshake of 20,000 and then a kind of 4,000 on top of that. That's to cover tax and national insurance payments. And then also £3,000 for non-clinical partnership skills. And from the 1st of March 2021, that was opened up to also include physician associates. I mean, I think for physician associates, you have to make sure that you're on the physician associate voluntary register and commitment to take on the full registration when that's actually put in place. So that opportunity is now there for not just for physician associates to become partners of GP practices, but that kind of incentive there to encourage them to take that on where it's made available. The kind of context for that is that the number of partners, particularly GP partners of GP practices, has been falling for a number of years. So why is that? One of the issues is, as a partner of a practice, you're the owner. So not only are you carrying out your clinical work as a GP or as a nurse or as a physician associate, but you're also then responsible for the running of the business. So you're the employer of all the staff. You're responsible for all the staff that work there. You own the premises or you have to lease the premises. So you're responsible for the premises. You're responsible for the contracts. So you have to deal with everything that comes with running a business as well as doing your clinical work. And for some, as the workload in general practice has gone up and up and up, it's just become too much, the kind of pressure of running the business alongside the pressure of all the clinical work. And so many GPs have got to the point where they thought, well, I haven't got the time or the energy to cope with this constant pressure. I would rather just get paid as a salaried employee, do my clinical work and not have to worry about the business. And so that's been happening kind of in the background. So the point of this incentive is to say, let's not let that trend continue because we don't want to get to a place where there aren't enough partners to run the business. So let's, one, encourage more people to sort of share that load. And second, let's put some training in place so that people who take on that load, because often, even with GPs, they can become a partner in a business, but not really understand anything about running a business. And so it's quite daunting to then suddenly find yourself looking at profit and loss accounts, looking at sets of things that you knew nothing about and being asked to make, employment decisions and tax decisions and talk to accountants and all of those things. And so having the training to support people to understand what it is they're doing and how to run a business effectively, I think is a key part of the scheme and how I think hopefully it will work and support general practice going forward.
The contract that practices sign up to, is often within normal working hours, office hours, Monday to Friday, 8 till 6, something like that. And some of the things that physician associate students often ask me to sort of explain to them is how out of hours services work in GP. Could you explain a little bit about how that's structured as well?
Yeah, so there are three parts to that. So there's core services in GP practice at 8 till 6:30. Okay, and then there's something called extended hours, which is part of the contract for GP practice where there's a set amount of extended hours. So hours that the GP practice has to provide outside of the core hours of 8 till 6:30. So that's extended hours. Then there's extended access. So that's really offering the service 8 to 8, Monday to Sunday. And often that's then carried out by a federation or a contracted provider. Often that isn't the GP practices themselves. The GPs might choose to then go and work in the extended access service, but that's often provided sort of outside the sort of core contract of the individual GP practices. And then there's the out of hours service that used to be part of GP practices. So this is the sort of 24/7. So this is like, how do you cover the kind of 8 p.m. to 8 a.m.? But back in 2004, that was taken out of the core GP contract, and that was basically offered out to tender. So basically the commissioners would then tender that service, and they would find new contractors to come in and deliver that service. So the sort of 8 p.m. to 8 a.m. is delivered by a contracted company. And each area has its own sort of specification, but they basically have to provide telephone advice and face-to-face where it's needed. For primary care networks, the expectation is that the extended hours and extended access, the funding for that and the responsibility for delivering that will come to primary care networks from April 2022.
The other topic I had written down sort of to help clarify for people was what QoF is all about.
Yeah, so the GP contract is divided up into different elements, but a key part of it is called QoF, or the Quality and Outcomes Framework. This basically trying to pay practices for outcomes that they deliver for their local population. There are a set of targets that GP practices have to achieve, and there are a set of points effectively. So there's a certain amount of points for say for diabetes, and a certain amount of points for COPD, and there are specific targets related to each of those areas. And then there's an amount of money per QoF point, and that's always negotiated in the GP contract each year. So the way to think of it is there's a part of the GP contract that is this quality and outcomes framework, and that the GP practice then has to work to deliver those outcomes in order to secure that funding.
Okay. Which brings me on to another question, I guess, about looking ahead for physician associates and for general practice more widely. In the short and in the sort of longer term views, how do you see general practice evolving, and how do you see PAs being a part of that?
Well, I think it's a really interesting time for general practice. One of the things to look out for in government policy is, what is it trying to do with general practice? And for many years, up until 2019, and probably at least the 10 years before that, the primary focus of government policy was about improving access to GP practice. They were really, really keen to try and move it to an 8 to 8 service with e-consultations and just available all the time. I think we saw a shift with the 2019 contract towards primary care networks, that I think the big sort of policy shift is saying, so GP practices as 7,500 independent businesses have felt a little bit separate from the rest of the system, separate from community care, separate from secondary care, separate from social care. And so I think the shift to primary care networks is to say, how can we create general practice as in primary care, focused around the needs of a specific population, this 30 to 50,000, and how can that how can it then work in partnership with the council, with community services, with the hospital, with social care? How can they all work together to improve the outcomes for that population? Of course, that's happening within this context of NHS policy of moving away from the purchase provider split that it's had for 30 years into this idea of integrated care systems and organisations working together to deliver the best outcome for patients. So I think there's this really important kind of context that general practice is operating in. So I think, and so what you've then got as a key part of primary care networks are these additional roles. And the additional roles are doing two things. So one is they're bringing this additional capacity into general practice that's much needed. But the second thing that they're doing is enabling practice through primary care networks to carry out activities and actions that are for the benefit of that, that 30 to 50,000 local population. So we've started to see that with care homework. We're seeing that with kind of the medication reviews. So some of the early specifications that have come in for primary care networks, they're going to move into things like personalised care, anticipatory care, this expectation of joint working with other organisations to deliver those primary care network specifications. So I think physician associates and these additional roles are going to play this crucial part of enabling general practice to not only be able to manage the consistently growing workload, but also to be part of this like local population health organisation that can work with other places to deliver real changes to care. And so I think it's an exciting time because it's something that's new, something that's moving away from contractual into something that feels more about whole populations and about making a difference. But of course, anything new obviously means it's a period of change, which means it can be difficult as well. So it's a challenging time, but I think an exciting time.
Ben, thanks so much for joining me on the podcast today. If people have found this useful and interesting, I really recommend that they check out your podcast as well, which is called the General Practice Podcast, and new episodes come out weekly. There's a phenomenal amount of information in your back catalogue there to help people understand more about primary care. If people want to get in touch with you, what's the best way for them to reach out?
Thanks for that, James. Yeah, you're right. We do have, I think we've got 250 back episodes now. They're all available on our website, which is Ockham, OCKHAM.healthcare. And like you say, yeah, new episodes out every week, and they can subscribe via all normal podcast providers. If you want to get in touch with me, my email is ben@ockham.healthcare. So yeah, just drop me an email.
Brilliant. And I'll leave links to your podcast and some episodes that are specifically about physician associates in the show notes of this show, so people can find them there. Thanks, Ben.
Thanks, James.
Thanks for listening to the Physician Associate Podcast.